The fields of orthopedics and traumatology are rapidly changing with the advent of new technologies and practices. But how can medical professionals ensure values are maintained in a time of building pressure? How can patient-oriented healthcare be maintained? To discuss these challenges, experts from around the world are meeting in Berlin for the German Congress of Orthopedics and Traumatology. In numerous sessions, talks and discussions over 4 days, they will connect with colleagues, learn more about new diagnostics, treatments and solutions for responsible patient care. At the largest European Congress in orthopedics and trauma surgery, 11,000 delegates will attend around 1,800 presentations on topics ranging from arthritis to trauma management, from complications to innovations. And to make sure you don't miss a thing, DKOU TV will be right here, bringing you the latest updates from the Congress. Welcome to DKOU TV 2019. We're here at Messe Berlin to bring you insights into the latest developments in orthopedics and traumatology. We have an exciting program of interviews and in-depth reports coming up, focusing on everything from knee simulators to periprosthetic infections. We will be at the Congress every day to find out more about some of the sessions and events that are happening here. So stay tuned to find out more. But first, let's have a look at what's coming up on today's program. The German Congress of Orthopedics and Traumatology attracts not only attendees from Germany, but from around the world. This makes it a fantastic opportunity to exchange ideas with experts from other countries. We sat down with Professor Daniel Berry and Professor Francesca to find out more about orthopedic trends in the US and Italy. Now joining us, Professor Daniel Berry. Thanks for being here.
It's a pleasure.
Tell me, what are the current trends in orthopedics in the US?
Well, it's interesting. In the last probably 5 to 10 years, there's been a lot of emphasis on refinement of procedures which have been developed 15 or 20 years ago, but have been made quite a bit better. There's been an emphasis on being able to do more difficult, challenging procedures and do them safely. There's also been an emphasis on perioperative management. A lot of effort to try to minimize patients' risk factors going into surgery so that surgery can be done more safely with fewer complications. And quite a bit of effort to do a better job of managing patients after surgery with better pain management, better management of blood products and less use of blood products. And finally, there's been quite a bit of work done with large databases and publications to try to understand associations between problems, complications, and how to prevent them.
Have there been some developments in the last year you recently hoped for, which came true?
Yes, I would say that that's probably true. My field is hip and knee replacement, and probably the biggest change in hip and knee replacement in the last decade has been improvements in materials. Materials have gotten better, so we can now reliably tell younger patients that if they have a joint replacement, the chance of it lasting them many, many years, and perhaps even their lifetime, is drastically different than it was in the past.
Have you noticed any differences in approach in other countries?
Yes, of course, every country has things that they're working on, but I would say that one of the most interesting developments for me has been watching how technology diffuses much more rapidly around the world now than it did even 10 years ago. 10 or 15 years ago, something might happen in North America and Europe. It would not diffuse around the world for many years. Now it's measured in hours, weeks, or months, but not years.
So what will be the developments in orthopedics in the future?
It's an excellent question, and we can see the future coming quite quickly. One thing that's happening for sure, very, very fast in North America, and I'm sure in Europe, is the digital environment is changing what we do in medicine. So we can see artificial intelligence coming quite quickly. We can see machine learning coming quite quickly. We can see natural language processing coming quite quickly. There's no doubt those developments will have a huge impact in diagnostics, in radiographic interpretation, and probably also in decision-making in orthopedic surgery. That's one area. A second area is improvements in technology in the surgery we actually do. So there is quite a bit of effort going into robotics right now. It's probably not fully developed yet, but it will get there. We can see in the next decade. And also in three-dimensional printing of objects and the ability to personalize the implants that we use, which is something we did not have in the past. Lastly, and maybe importantly, we see biology coming in orthopedics. In the past, it's been a lot of metal and plastic. In the future, it's going to be biologic. And we can see the seeds of regenerative medicine, the foundation of which has been built over the last 10 or 20 years, starting to bear fruit. And I'm quite sure over the next decade or two, we will see dramatic improvements in the biology of what we can do.
And for the next generation of young people becoming doctors, will it be easier for them than for you?
I think every generation has its challenges. And so now more information is available at the fingertips of younger doctors and surgeons, but there's a lot more to know. And technology makes the pace of change quite quick. So every generation has its challenges.
To talk a bit more about current trends in orthopedics, we'd like to welcome Professor Francesca. It's nice to have you here.
Thank you very much for the invitation.
How are you?
Fine, thank you. I like to be here. It's a very great pleasure to join this wonderful Congress.
What are the current trends in orthopedics in your country?
Actually, Italy is a special country because we are facing a significant increasing on the mean age of the population. What means that today we are actually the oldest country in Europe. Our over 90 years of age are about 800,000 people, which means that we are significantly concentrated and dedicated to fragility fractures. This kind of population, we have about 25% of the population is over 65 years of age, which means that the osteoporosis and fragility fractures is significantly affecting our activity daily. And as a matter of fact, in our country, all the attention in the main hospital, public hospitals, is given to this kind of population. What does it mean in orthopedics? It means that we have to deal with a weak bone, with recurrent fractures, with periprosthetic fractures, and with bone where you cannot use normal devices. And because of this, we're trying today to develop and use all different devices that might increase stability, long-term device in terms of quality of life for the patients. And that's very important because, of course, everything runs about this kind of aspect and this problem.
So have you noticed any difference in approach in other countries?
A little bit, yes, because as I mentioned, other European countries are much younger than we are. I don't want to sound like an old person, but actually our country is facing this big social problem. So today there's not big difference among different countries. I mean, we're by internet, orthobolets and Vumedi, we are connected every day. 15, 20 years ago, to find a new technique, you had to take a plane, take a journey, a few days off your work. Today, you just go on the net and you see everything. So it's not big differences. It's just a matter of a social difference in terms of budget, in terms of capacity, of organization, but not big difference in terms of technologies.
So have you found out about some new trends here at the DKOU?
Actually, it's my first time at DKOU, and I will enjoy it as there are many significant and very interesting sessions. We've been given by the DKOU president's special part as a guest nation, as Italy has been with Canada guest nation. So we are discussing a lot of total knee replacement, a lot of hip replacements. So there are main sessions where being especially trauma. And here in Germany, trauma is a significant part of the activity. So I find that this is probably the most important part of this Congress.
So with Italy having the oldest people in almost Europe, you have special treatments to do. So my question is, what developments in orthopedics do you expect from Italy in the future?
I might make a joke, have younger people, but that's not possible. So to make our life easier. But actually what we'll face in the future is develop more and more devices and augments that will probably increase in terms of prevention the kind of weak bone, osteoporotic bone that we're facing today. And what we've seen, we're gonna, of course, basing on registers analysis. We are trying to change our attitude, especially in terms of joint replacements. We are seeing today that cementless implants for the hip, they have a 30% more possibility to have a 30% fractures, which means that we want to reduce this by changing our attitude and go more toward cemented implants. So in order to reduce preventing this kind of fractures.
Thank you for your time.
Thank you very much to you.
Up next, we take a look at the Pulse lecture, where Professor Daniel Berry and Micha Borka, chief designer of Lamborghini, discussed the motto "Form follows function."
Natürlich ein ungewöhnlicher Vortrag vor so einem Publikum, als Designer zu sprechen. Form follows function. Wer hat das eigentlich designt, das Auto? Der oder der Marcello Gandini?
Now, when I was assigned this topic, I have to admit that it was a little bit of a head scratcher. I thought to myself, what does form follows function really mean? And how exactly could it apply to orthopedic surgery? It's said to have been coined by the architect Louis Sullivan, related to modern skyscraper design. And he felt the form of a building should follow its function. But that was distilled down to the concept of less is more. You know a lot about that because of Bauhaus disciples that you're all familiar with. So I thought about that for a little while, and I realized that it is true that there's an analogy between orthopedic surgery and architecture. And when we design implants or procedures for reconstruction, we are in essence performing the role of an architect in designing a building. And then when we actually do the surgery, we're performing the job of the construction company. Simpler implants and procedures are better. As the architect said, less is more. Second, respect the biology. For a biologic organism, biologic answers are best. Biologic form and function should follow one another. And lastly, respect the body's own form. It's evolved over millions of years. And the closer we reproduce the body's own form with our surgeries, the better the function ultimately should be.
Next up, we take a closer look at the University of Orthopedic Research and Biomechanics at the Ulm University Medical Center, where researchers focus on a broad research spectrum, including bone regeneration and joint biomechanics.
Unser übergeordnetes Forschungsziel hier im Haus ist die Erforschung von Störungen der Funktion und Regeneration muskuloskeletaler Gewebe. Natürlich mit dem Ziel, die Grundlagen besser zu verstehen, in die Klinik zu transferieren und letztlich verletzten und erkrankten Patienten helfen zu können. In unserem Institut arbeiten derzeit ungefähr 40 Mitarbeiter. Dazu kommen etwa 20 Studenten und Doktoranden. Wir sind hier im Haus ein sehr interdisziplinäres Team. Es arbeiten hier Biologen, Molekularbiologen, Mediziner, Tiermediziner, Ingenieure, Informatiker und dadurch kommen natürlich sehr viele verschiedene Expertisen zusammen und wir haben ein sehr breites Portfolio an Methoden für unsere Forschungsarbeit zur Verfügung.
Unsere Forschungsschwerpunkte im Bereich Knochenbiologie sind, dass wir verstehen möchten, wie der Knochen auf- und umgebaut wird. Außerdem möchten wir die Pathomechanismen von altersassoziierter und postmenopausaler Osteoporose besser verstehen können. Außerdem möchten wir verstehen, wie mechanische Reize auf den Knochen wirken und uns dies auch therapeutisch nutzbar machen. Im Bereich Knochenregeneration interessieren uns die molekularen Grundlagen der Knochenheilung. Eines unserer Hauptziele ist, besser verstehen zu können, wie Begleitverletzungen und weitere Traumata die Knochenheilung beeinflussen können. Im Bereich Knochenforschung verwenden wir, um molekulare und zelluläre Mechanismen aufzudecken, in vitro verschiedenste Zellkulturmodelle und in vivo können wir transgene Mausmodelle nutzen. Außerdem machen wir histologische und biomechanische Analysen und uns steht ein hochauflösendes Mikrocomputertomographiegerät zur Verfügung.
Ich bin verantwortlich für die Forschung zur Bandscheibe, Meniskus und zum Knorpel. Die Forschungsschwerpunkte sind es, die Degenerationsmechanismen zu verstehen, Möglichkeiten der Regeneration zu finden und Therapiekonzepte zu verbessern. Eine Besonderheit unserer Forschung hier ist, dass wir ganz speziell entwickelte Modelle haben, in denen wir diese hohen Belastungen, die in diesen Geweben vorherrschen, simulieren können. Ein weiteres wichtiges Ziel ist es auch, neue diagnostische Marker für die Behandlung dieser degenerativen Krankheiten zu entwickeln und zu finden. Hohe Dehnungsapplikationen können wir machen, wir können hydrostatischen Druck applizieren. Und eine Besonderheit ist, dass wir mittlerweile auch viele Versuche im Organkulturmodell machen. Das heißt, wir haben Modelle, mit denen wir Gewebestrukturen für längere Zeit am Leben erhalten können, im Labor, unter Laborbedingungen und dann dieses Zusammenspiel von Belastung und Entzündungsprozessen beispielsweise simulieren können.
Ich leite den Bereich Gelenkbiomechanik hier im Institut. Der Hauptfokus liegt auf dem Kniegelenk. Speziell haben wir uns in den letzten Jahren auf den Meniskus gestürzt. Wir haben hier im Institut verschiedene Gelenksimulatoren entwickelt. Einen traditionellen, der mit relativ langsamen Bewegungen funktioniert und geringen Gelenkkräften. Das hat uns aber nicht ausgereicht. Deswegen haben wir in einem großen DFG-Projekt einen neuen Gelenksimulator konstruiert und haben dabei festgestellt, dass unter großen Belastungen und auch schnellen Bewegungen sehr viel höhere Kräfte entstehen. Zusätzlich zu den Gelenksimulatoren können wir Bewegungen analysieren mit speziellen Kamerasystemen. Wir können aber auch Gelenkflächen zum Beispiel biomechanisch abscannen. In Zukunft werden wir uns speziell auch auf die Rehabilitationsforschung stürzen und das können wir eben mit unserem neuen Kniegelenksimulator sehr gut machen.
Ich leite die Wirbelsäulenforschung bei uns im Hause. Ziel unserer Arbeit ist es, dass wir versuchen, die knöchernen Strukturen, die Bandscheibenstrukturen einer degenerierten oder verletzten Wirbelsäule zu verstehen, um dann Therapieverfahren oder Operationsmethoden zu entwickeln, zu verbessern oder neue uns auszudenken. Hierfür haben wir eine ganze Reihe von Belastungs- und Bewegungssimulatoren, um diese dann experimentell mit unseren Finite-Elemente-Methoden zu untersuchen. Wir versuchen in unserem dynamischen Wirbelsäulenbelastungssimulator ganz aggressive Bewegungen zu simulieren, die vielfach wiederholt werden. Und wir können damit unter aggressiven Testmethoden Bandscheibenvorfälle erzeugen, wie sie beim Patienten tatsächlich gefunden werden.
Wir freuen uns sehr, dass wir dieses Jahr einen großen Forschungserfolg erzielen konnten. Der Wissenschaftsrat hat uns ein Forschungsgebäude bewilligt zum Thema multidimensionale Traumawissenschaften. An der Antragstellung waren natürlich viele Kollegen hier am Standort beteiligt. Herr Professor Huber-Lang aus dem Institut für Traumaimmunologie und ich sind die Gründungsdirektoren dieses neuen Forschungsgebäudes. Zwischen 15 und 20 Arbeitsgruppen werden zu Fragestellungen der Traumaforschung zusammenarbeiten. Grundlagenforscher wie klinische Forscher, multidimensional vom Molekül über die Zelle bis zum Organismus und wir interessieren uns auch für die Interaktionen von physischem und psychischem Trauma. Nächstes Jahr feiern wir unser 30-jähriges Bestehen hier am Standort Ulm. Wir freuen uns, dass wir über die vergangenen Jahre gute Forschungsarbeit geleistet haben und unser Ziel ist es natürlich, das auch in Zukunft zu tun. Das Institut ist über die letzten 30 Jahre stetig gewachsen, die Mitarbeiterzahl ist vergrößert, die Forschungsbereiche sind ausgeweitet, sodass wir für die nächsten Jahre keine Angst haben, dass uns die Themen ausgehen.
I'm now joined by Professor Benedict to discuss preparations in Germany for the event of a terror attack. Thanks for being with us today.
Nice to be here for me.
So what preparations have been made in Germany for the event of a terror attack?
In the year 2016, the German Society of Trauma Surgery and the Medical Service of the Armed Forces in Germany are starting a program, a 5-point program, to inform the complete country about the situation of terrorism and the results after a terrorism attack. The first 2 points are a program to inform the trauma networks. We have trauma network in Germany to inform the cities and the governments and the politics to the problem terrorism and the differences to the normal muscle situation. The third point was to develop a core system to train the doctors in the hospitals. The fourth point is to develop a register for gunshot wounds And the fifth point was to do more connection between the German Society of Trauma Surgery and the medical service of the armed forces, because in a terrorism attack we have much patients than in a normal muscle situation, and they have special wounds. So we don't have any experience to treat them. Only we have the experience to treat war wounds in the military, because we are on missions out of Germany. And I think the combination of the DKOU and the medical service of the armed forces is a very good connection to help the clinics to treat this situation.
In your opinion, what still needs to be improved to make it perfect, the concept?
I think we have to bring the knowledge about this problem more in our country. There are some cities and some states in our country, they are do very much. They had learned that it's very necessary to do something against these terrorist attacks and to prepare the clinics and the medical system. But there are some clinic states, they don't want to do anything to this problem. It's unbelievable.
Yeah, it's dangerous.
It's dangerous, right? But it is so, and I think the main point is to bring the information more in the country so that the others are coming on this plan. This is 5-point plan we have performed, and to start to perform the hospitals and so on to this problem. For the clinics, it's quite equal. If the attack is from Islamic terrorism, it's an amok, or it's a right terrorism or so, there come people with gunshot wounds, and that's our problem. And they're coming very much people, they come in a quick time. We have to think that in a normal medical situation, car accident or so, the first patient is coming 60 minutes after the accident. And in the terrorism attack, the first patient is coming after 10 minutes. And the clinic don't know anything about that there is a terrorist attack. There are coming 20, 30 patients and they don't know why. That's the difference to a normal muscle situation. The reason for that is that the patients at the attack ask, where is the next hospital? They don't ask, where is my best hospital? Sondern there is a bombing, and then the people who can run and they are a little bit injured, but they can walk by themselves, they ask, where's the next hospital? And they go to the next hospital. And there are coming all people. That's a great problem.
So I hope that all of the hospitals get to know the 5-point plan and will also realize it.
Yes, that's the problem.
Thank you very much for being here.
Okay, nice to be here.
Next up is the Department of Orthopedics and Traumatology at the University Hospital of Basel. The department stands out due to its strong team spirit and interdisciplinary collaborations with experts from other fields.
Wir sind hier am Universitätsspital Basel, der Klinik für Orthopädie und Traumatologie. Wir haben derzeit 7 verschiedene Teams, 3 davon sind wissenschaftliche Teams. Des Weiteren haben wir auch interdisziplinäre Teams wie das Infekt-Team oder das orthogeriatrische Team. Ein wichtiges Merkmal unserer Klinik ist, dass wir die organisatorische Trennung von elektiven und akuten Patienten beibehalten.
Was die ärztliche Arbeit betrifft, arbeiten wir aber eng zusammen. Wir haben gemeinsame Rapporte, wir haben Rotation innerhalb der Teams.
In unserem Team, Team Oberextremität und Team Unterextremität, haben wir 4 leitende Ärzte, 6 Oberärzte und 6 Assistentärzte. Wir haben ein Pheno, womit wir normale Röntgenbilder aufnehmen können, aber auch 3D-ähnliche Bilder unterwegs während der Operation aufnehmen können. Es gibt uns die Möglichkeit, die Patienten besser zu versorgen und eine präzisere und bessere Repression zu erreichen. Zur Behandlung von komplexen Frakturen haben wir die Möglichkeit, einen 3D-Druck von einer Fraktur zu machen. Das ist eine Pilonfraktur, ein Dachdecker, 4 Meter gestürzt. Nun machen wir einen 3D-Druck 1:1 und wir können dann die Strategie ganz präzise und genau festlegen, bevor wir im OP gehen.
Und was wir im 3D-Print Lab machen, ist aus den Computertomographiedaten ein dreidimensionales Modell des frakturierten Knochen oder der gebrochenen Knochen zu berechnen. Und aus diesen dreidimensionalen Daten kann man dann ein 3D-gedrucktes Modell herstellen.
Der Fokus für unser orthogeriatrisches Team ist eindeutig die klinische Tätigkeit, die individuelle Betreuung des geriatrischen Patienten praktisch umzusetzen. Das umfasst zum Beispiel ein Delir-Screening, es umfasst ein Management von Malnutrition, eine standardisierte Osteoporoseabklärung, ein standardisiertes Schmerzmanagement, die wir speziell für die geriatrischen Patienten definiert haben. Traumatologe und Geriater gehen gemeinsam jeden Tag zum Patienten und beurteilen ihn. Wir haben auch einen kontinuierlichen Patientenpfad implementiert, sodass die Betreuung von hier, der Akutstation, bis in die nahegelegene orthogeriatrische Rehabilitationseinheit gewährleistet ist.
Das Team für orthopädische Infektionen konzentriert sich auf alle ambulanten und stationären Patienten, bei denen es zu einer Infektion im Bereich des Bewegungsapparates gekommen ist. Es braucht bei praktisch allen Patienten die Kombination des Chirurgen und des Infektiologen.
In der ambulanten Sprechstunde, da sehen wir die Patienten mindestens zu zweit, meistens zu dritt. Ein Orthopäde, ein Infektiologe und ein plastischer Chirurge.
Es ist in der Regel eine operative Therapie vorgeschaltet mit der entstehenden Diagnostik und der Behandlung des Infekts, der Stabilisierung von Knochen oder dem Austausch von Kunstgelenken und im Nachgang dann die Behandlung interdisziplinär mit Antibiotika.
In der Forschungsgruppe beschäftigen wir uns mit, wie Zellen sich organisieren können, um Gewebe zu züchten als Implantate für die klinische Translation. Insbesondere im Fokus von Geweben vom Bewegungsapparat, Knochen und Knorpel, um reproduzierbar diese Knorpelzellen zu züchten auf dreidimensionalen Gerüsten, um Gewebe zu generieren, die biochemisch, biomechanisch funktional sind.
In unserem großen Nase-zu-Knie-Projekt führen wir aktuell eine multizentrische Studie durch. Wir haben große Hoffnung in diese Therapie für die Zukunft. Erkrankungen am Knie wie fortgeschrittene Arthrose, die wir bis heute nicht gut behandeln können oder wofür man dann ein künstliches Gelenk implantieren müsste, hoffen wir, dass wir das in Zukunft auch regenerativ mit solchen gezüchteten Knorpelkonstrukten behandeln können und damit Patienten auch helfen können. Wir haben bereits 2 Patienten schon mit fortgeschrittener Arthrose als Einzelfälle behandelt und haben hier sehr gute klinische Ergebnisse erzielen können.
Vor der Operation war es dann wirklich so schlimm, dass ich wirklich die Treppe hochgekrochen bin. Ich wusste für mich eigentlich in dieser Situation, ich habe eigentlich nichts mehr zu verlieren. Man hat mir dann hier in der Nase den Knorpel entnommen, den wir hier reingemacht haben. Seither kann ich problemlos spazieren gehen, also ohne Probleme auch mal Stunde, 1,5 Stunden. Ich sage ihm, ich habe wie ein zweites Leben bekommen eigentlich.
Der Fokus in der Weiterentwicklung unserer Klinik wird sicher auf der Optimierung unserer Behandlungsabläufe liegen. Wir verlegen die Behandlung, die ambulante und die stationäre Behandlung unserer elektiven, orthopädischen, planbaren Patienten ins Bethesda-Spital.
Der Fokus der universitären Orthopädie am Standort Bethesda ist primär das ganze Spektrum der Orthopädie. Das Besondere der Abteilung ist eigentlich, dass wir hier das Beste von 2 Welten anbieten, der Public-Private Partnership. Wir haben einerseits das individuelle Umfeld des Privatspitals für die Patienten, andererseits aber auch die universitäre Orthopädie, die hier einen 24-Stunden-Service bietet, mit der Qualitätssicherung, die man von einem öffentlichen Spital kennt.
Die Auftrennung in Elektiv- und Notfallbehandlungsabläufe birgt natürlich ein bisschen die Gefahr der Aufsplitterung der Klinik. Wir sind aber so organisiert, dass die Spezialisierung im Fachlichen erst ab Stufe Kaderarzt stattfindet. Die Assistenten und die Oberärzte sind in einem Rotationssystem organisiert. Wir sind hier eine Universitätsklinik und wir nehmen diese Verantwortung sehr ernst. Wir sind überzeugt, dass die Weiterbildung ein Wert an sich ist, nach dem wir uns richten. Und man kann sogar sagen, die Weiterbildung ist eigentlich das, was unsere Klinik zusammenhält.
I'm now joined by Professor Meyer and Professor Lina. We will talk about the best treatment approach for geriatric patients. Thanks for being with us today.
Thanks for having us.
Thank you for the invitation.
What do you think traumatologists need to keep in mind when dealing with a geriatric trauma patient?
I think the most important is to keep in mind that these are completely different patients than the regular adults. We have comorbidities, we have problems with osteoporosis, we have problems with the mind of the patient, with dementia, with delirium and everything else. And therefore, I think a co-management with a geriatrician, which is in best position to deal with these problems, is one thing that the most traumatologists should keep in mind.
What do you think are the best ways to adjust your treatment pathways for dealing with the elderly?
I think you have to address the surgical challenge by your surgical technique, which is early arthroplasty, rigid fixation and stabilization with intramedullary nails. And you also have to address the medical challenges, and that is with protocol-driven care and geriatric co-management. And the goals of the protocol should be early assessment of the geriatric patient by a geriatrician and early surgical care within the first 24 hours, immediate postoperative weight bearing and mobilization, geriatric co-management for polypharmacy and the comorbidities, and early discharge planning. And I think numerous studies have shown that this results in a reduction of mortality and complications and an improvement of functional results. I think it is important to give yourself some credos in geriatric trauma care. Some credos like single shot surgery, which means the decision has to be made in the very first moment when the patient shows up. The best way to treat him with one operation. Mobility is over functionality. That means we have to keep them going, the patients. And it's a highly individual decision making in geriatric trauma care.
What do you think traumatologists often get wrong when treating geriatric trauma patients, and how can this be avoided?
I think the first misconception is that they think it's a singular orthopedic injury. And also the trauma surgeon might be the best person to treat the patient surgically, but not the best physician to address the medical problems. And that's why I think geriatric co-management is essential for these patients. In my opinion also, there's always to reach full weight-bearing mobility. That is one of the most important things from the traumatologist standpoint. Because we today know that conservative treatment might end up with a higher rate of mortality than operative treatment. And this is something pretty new. We always thought up till now that operative treatment is of risk for the patients, but the conservative treatment is in many, many cases more risky, especially with the mortality.
How do you think the treatment of geriatric trauma patients will develop over the next few years?
Hopefully, I think we can widespread it much more, especially the co-management with a geriatrician. Geriatricians are our natural friends. And trauma surgeons are natural friends of geriatricians. And I think this should be widespread all over the trauma units, which are dealing with geriatric trauma patients. I think we will have mandatory geriatric co-management in the hospitals that are treating geriatric trauma patients. And I think we will have an increase of the number of geriatric trauma centers and a decrease in the total number of hospitals treating these complex patients.
Gentlemen, thank you very much for your time. Have a great Congress.
Thank you. Thank you.
Up next, we take a closer look at trauma care in the southwest Netherlands. Find out more about the work of the trauma center in the region and the trauma department of Erasmus NC.
The Trauma Center is an organization responsible for the trauma care in our region. There's one level 1 trauma center. This is the Erasmus Medical Center. We will see each year about 450-500 polytrauma patients. In the Netherlands, we have 4 helicopter medical teams, 1 in Rotterdam. As a level 1 trauma center, we have all physicians staffed on the helicopter medical team, and they are very experienced in trauma care and non-trauma care but for critical ill patients.
I started with a project of providing pre-hospital thoracotomies, which is quite unique for the Netherlands. We now are researching if REBOA, resuscitative endovascular balloon occlusion of the aorta, is another option. The average rates of survival for emergent thoracotomies are similar to South Africa and the USA, and that's mainly due to the collaboration we have with our Ministry of Defense.
The Erasmus Medisch Centrum has a close and very active collaboration with the Ministry of Defense, with the Armed Forces. We bring our war experience to the hospital and can use that in this very large trauma center. Also, we can keep our skills up to date, obviously. So we work with everybody, and we normally work in white, like everybody else here.
In the Netherlands, the trauma surgeon is head of the trauma team, and he is experienced in fracture care, but also in soft tissue and thoracic and abdominal trauma. We do damage control laparotomy or resuscitative thoracotomy, and also intervention radiology is possible 24/7 a day.
We do a stabilization in the ER department, and subsequently we have OR facilities at the ER, in the OR. We have intensive care units or in stable patients a ward. The team consists of 8 consultant trauma surgeons, so we are quite a large team, but on top of that we have pillars, certain specific expertises, and we have organized that in teams who take care of specific parts of the body.
In our hospital we see many multi-traumatized patients, so we have a very low threshold to do a CT scan of the thoracic cavity. I'm especially focusing on the presence of rib fractures. Rib fractures are, up to me, underestimated, and we need more data on how to treat these fractures. That's why we set up a multi-center randomized controlled trial for multiple solitary rib fractures, to operate on them, and the other arm we don't operate on them.
We see approximately 80 to 100 patients with a pelvic injury a year that need surgical treatment. And we have a hybrid OR in which we can perform minimally invasive treatment with high-end, high technical resolution and software that provides us the possibility to be very precise in what we do.
We have done some RCTs, a randomized controlled trial on proximal humeral fractures. And for example, for elbow injuries, instability of the elbow, we will treat this with an external fixator, a dynamic one, with immediate mobilization afterwards, because we like to prevent stiffness. And we have very good outcome and satisfaction of these patients.
With regard to lower extremity, especially the lower leg, we have an excellent collaboration with our plastic surgeons, and even in the middle of the night or at the weekend we have the opportunity to do a definitive treatment in a very early phase. We have research projects going on, for example the effect of certain nailing techniques with regard to complaints on the long term. We also have been involved in the development of specific new implants that are antibiotic coated.
One of the other projects we started about 2 years ago is the osseointegration program. The procedure of osseointegration is when we use titanium implant. The femur is reamed to the diameters of the implant, and the implant is put press fit into the femur, and then by partial loading the bone will grow into the implant, and then the patient is able to move his prosthesis and there's no need of a socket anymore. Surgery is only a minute part of the procedure. Real work for the patient, the rehab program, it takes about 3 months at least.
We have a collaboration with the Technical University of Delft to see if they walk better, just the quality of walking, and if they can walk longer. We also do training programs within Europe to learn how to do the osseointegration procedure and the screening before the surgery and the rehabilitation program afterwards.
I had an operation 2 years ago and I'm happy with it, what I have now. With the other operation that I have, the symptoms was very painful. With this, you can walk freely. I can on the bike, I can shopping, I walk on the stairs. The quality of life is back to me. The socket is gone and the pain is gone.
We also see many patients who are referred from other hospitals with problems with fracture healing, like infected non-unions or bone segment defects. This is a circular fixator, which you can use with an infected non-union, for example. Also in patients who have a post-traumatic limb deformity. And then with the rings and a computer model, we can adjust the position of the fracture. There are not many hospitals in the Netherlands doing this, so I'm quite proud to be able to do this.
We are also participating in international education programs. We are running courses together with international colleagues. We are also going to visit other hospitals to stay in the front line of the treatment of trauma patients.
Next, we take a look at two of the many events happening at the DKOU. The Trauma Couch allows experienced surgeons to discuss a difficult case and exchange ideas for the best form of therapy. Audience participation is strongly encouraged, and the informal setting invites debate on a high level in a relaxed atmosphere. This year's Science Slam takes a similar approach to education, making learning everything but boring. Each participant has only 8 minutes to present their research and get the support from the audience to win the slam. Learning and laughter guaranteed.
I think the best thing about Science Slam is that you remember the talk so much better if you laugh while you hear that. So even really difficult scientific results can be presented in a good way, so you can remember them.
We did like a presentation at work not too long ago that was kind of funny, not intendedly funny, and then the idea was born that we would participate here. I think it was the special about the atmosphere was that you, after like 1 or 2 minutes, you kind of forget that you are in front of like a super professional panel, and you just feel like you're amongst peers, and I don't know, had like a very young vibe. It was very easygoing, and it was a lot of fun.
You're afraid you don't know the people, but when you go on stage, you forget that. You have lots of colleagues and friends there, and so you basically know that it's gonna be good, and you're gonna have a good time, and you can hear the people laughing, enjoying your talk. So I really like the atmosphere.
The feeling was pretty good because I didn't see my director of the university in the crowd, so I was not too afraid to say something wrong. I decided to participate in the Science Slam because there was money to win. That's not the real reason. I just like to do things I've experienced in Science Slams and did it before. And the second most important reason for me was that you can combine scientific facts and your own papers and publications in a comedian way, and you can reach more people, and you can try to explain difficult situations in a more easy, more comedian way.
Another fantastic day at the DKOU as the Congress draws to a close. That's it for this year from us here at the DKOU TV. We hope you enjoyed our program and the rest of the Congress. Remember, you can still watch the show online via the DKOU 2019 website and our YouTube channel. So keep watching and keep in touch. We'll see you next year.